So presented at the SGO this year, 2019, was a randomized prospective phase 3 trial of avelumab, another checkpoint inhibitor, versus pegylated liposomal doxorubicin, kind of as the control, and then the combination of PLD avelumab. And that study was, well, you tell us. Lena, what did that study show?
Well, that study, unfortunately, was not a positive study. Part of the issue with the study is that the patients were not pre-selected according to their potential targeted mutations. And I think that's a lot of what we're talking about today, is that so much of what we do now is really better understanding of the biology.
There's no PD-L1 expression, right? That wasn't the endpoint.
Right.
But if it would have been, maybe it would have been positive.
It would have sub-selected patients who actually had a chance of responding to it.
And that's what Katie said, that there's maybe an enrichment.
Maybe.
So should our IO therapies just have as the endpoint PD-L1 positive patients, Brian?
It's a great question. We don't know the specific answer. We have to look at it. It maybe. I think it is a predictor, or one of the multiple predictors of potential response. Again, in general, these ovarian tumors, they're cold tumors. They're not tumors that are immediately, they're cold tumors. So I think when we're moving forward in IO therapy for ovarian cancer, we have to think about combination therapies. And I'm not sure, it may be combined with a radiation. It may be combined with a different type of chemotherapy or another targeted therapy. Maybe it's before or after surgery, but a combination therapy, in general, the principle is to turn that cold tumor hot, something that'll be recognized by immunotherapy. I'm not sure if PD-1, we know that it's not just PD-1 expression.
So let's talk about some of these combination trials, because seems like they're everywhere. For the frontline treatment of ovarian cancer has been defined with bevacizumab and with olaparib in BRCA-mutated patients, and maybe PALA-1 with olaparib-bev, but there are even more combinations. You run a study called Imagine 50. It just closed to enrollment here. Tell us about what Imagine 50 is and what the hypothesis is there.
So Imagine 50, the hypothesis is that if you combine anti-angiogenic therapy with immune checkpoint inhibitors, that they will be synergistic, that you will, and we know this when you block VEGF. VEGF is a really immunosuppressive molecule in addition to being pro-angiogenic. Both indirect and direct effects on the immune response, and one of them is that it decreases T cell trafficking to the tumor. So if you block VEGF through a number of ways, but hopefully with bevacizumab, you'll increase T cell trafficking to your tumor and improve the ability of the immune system to respond. And that has been borne out in tumors that have a demonstrated response to immune therapy, so renal cell cancer, lung cancer, and some in breast. Breast gives us the most hope that it will be helpful in ovary, because breast has not been an immunoreactive tumor
I'm
either.
going to repeat that, because it works where IO already works.
Correct.
It's never been shown to work where IO doesn't work.
Except there's a signal in breast. So that's
There's
what we're
a signal
hopeful
in
for.
ovary too.
Signal in ovary too. So that's right. There are signals in ovary. We can talk about those smaller studies, but that's the hypothesis. Yeah. And so it took patients. It did stratify by PD-L1.
Which is the only study that does that, to your point of these frontline
And it was hard to do.
I know.
Because you had to wait until we did your testing.
I know.
Your patient had to wait. And so it was hard to do. But it is stratified by PD-L1 expression by a different score than the CPS, but a very good assay. And one arm gets chemotherapy bev maintenance, and the other gets chemotherapy bev maintenance with atezolizumab.
And when do you think that's going to read out? Because it just finished enrollment.
It just finished, so I hope it doesn't read out until 2021.
So the patients get lots, because it's an event-driven analysis.
It's an event-driven analysis, so I'm just sitting back and I'm hopeful that we're going to just see patients do well.
So that's IO anti-angiogenic. Certainly within the energy, they have olaparib, cediranib, a fully oral regimen. Brian, tell us about Duo-O.
Okay, so Duo-O, that's basically an activity trial looking at a combination of durvalumab with olaparib in patients with recurrent ovarian cancer, looking for to see if it could enhance activity. Right now, the activity part of it was read out, and I forgot the exact percentage. It's a modest activity. The problem with those trials, until we do head-to-head comparisons, we don't know if the activity is driven by one or of the other, or if it's truly a synergy, which is what we would hope.
So we got Imagine 50, atezolizumab, bevacizumab, Duo-O, that's durvalumab and olaparib, and because olaparib is shared with Merck, there's a virtually identical trial called OV43 with pembrolizumab and olaparib. The difference between these two, though, is that they allow bevacizumab, so there'll be some triplet therapy, which would be bevacizumab, olaparib, and then pembrolizumab or durvalumab. Talk about financial toxicity, $30,000 a cycle. And then I run a trial called Athena. Athena is a pure maintenance trial. We were struck by the Javelin 100 press release. In addition to Javelin 200, which did not meet its primary endpoint, Javelin 100 was avelumab frontline. And it was with chemotherapy and in maintenance, which should have worked, or also in maintenance, who knows, but it didn't work either place. And you talk about breast, there's a very large distinction between breast cancer and ovarian cancer, and the classic example is the recent approval of atezolizumab and nab-paclitaxel.
Right.
So when you give single-agent chemotherapy and atezolizumab, it works, New England Journal,
Yep.
okay, FDA approval in breast. When you give PLD and avelumab, it's negative, and well, they say maybe we should have studied PD-L1 expression. So the Javelin 100, I think, speaks to maybe the opportunity of a pure maintenance opportunity, that maybe adding chemotherapy and IO doesn't have an opportunity. So that is nivolumab and rucaparib. So there are a number of trials, and I guess the final would be FIRST. Tell me about FIRST.
FIRST is a randomized phase 3 study that enrolls patients with advanced stage disease and randomizes them. Bevacizumab is optional, you have to declare it. So it's Taxol carbo, presumably Bev maintenance, versus Taxol carbo, Bev maintenance, niraparib maintenance, versus Taxol carbo, Bev, TSR-042, which is their Tesaro's anti-PD-1. It does have a name now.
Dostarlimab.
Dostarlimab, thank you. And leading into Bev, niraparib, dostarlimab maintenance. That study is stratified by BRCA status, and if you have a BRCA mutation, you are not randomized to a non-niraparib containing arm because the randomization occurs in cycle 2. So it's an adaptive randomization. It's an interesting study. As these read out, PRIMA and other things read out, if things are positive, it will adapt and change randomizations to adapt to the new standard of care.